Okay, great. Now we've got all of the technical issues worked out for now. We're actually officially ready to get started. So again, thanks to all of our viewers for being with us around the globe, wherever you are. We're so glad to have you for this very important conversation that we're having. And this panel is going to focus on the innovations in health. And we've got a fantastic panel with a number of great experts who are working on some phenomenal things. And I can't wait to get into it. But before we do that, I just want to take care of a few housekeeping things for our guests who are with us. We do want you to be sure to visit our expo panels and see all of the exciting things that are going on with the videos there. In addition to that, do not forget about the networking sessions. You can feel free to join our networking sessions at any time. And also, if you find someone that you're speaking to and you would like to extend the conversation, there is a feature that will allow you to do that. So it's kind of like speed dating. So if you find a match and you actually really like the person, you can actually continue to talk to that person. How cool is that? And also, if you just want to find and connect with someone that you do not see in the networking session, you can just simply reach out to them. Just look at the information on the right-hand side of your screen to be able to do that. And lastly, I do want to also thank our sponsors for participating and supporting this conference today, Cigna, Children's, Kaiser Permanente. We certainly appreciate all of your effort for helping us put on this great conference. And now let's get into the heart, because we know for many of our participants, that's what you're here for. And as I said, we've got a great lineup of doctors. And we have with us, and I'm just going to start with each one of you and talk a little bit about some of the things that you are doing that you can share. And I'm going to just start with the person closest to me, Dr. Bruce Wollman, who's at Kaiser. And I want you to speak, Bruce, just a little bit about what you all are doing at Kaiser. Specifically, you and I talked about the reduction of sleepless nights and how Kaiser is actually working on reducing the sleepless nights, particularly around breast cancer screening. So talk a little bit about that innovation in your opening, and because I think that's something, particularly for many of the women who are watching, that's something I think that will be of very keen interest to them.
Sure. Thanks so much, Eric. First of all, just wanted to express my appreciation for being on this esteemed panel and the great group hosted by the Washington Diplomat. It's really an honor and a pleasure to be here. I think talking about innovation is something that we do each and every day here in Kaiser Permanente. Our organization is probably familiar to folks who have more nationalized health services around the world, in that we take care of a population of patients. Here in the Mid-Atlantic, in Washington, D.C., Maryland, and Virginia, we have about 800,000 patients where we take care of from when they're healthy to when they're sick. And thinking about a key issue for our older female patients, of course, as you said, is breast cancer. Breast cancer is a disease where there's a lot of fear in. We have in the United States a postage stamp for breast cancer awareness. There's not a postage stamp for appendicitis or other things. And so there's a law in the United States that says a woman getting a mammogram, a screening examination for breast cancer, has to get her results in writing within 30 days. Now, breast cancer isn't going to, kill a patient rapidly over 30 days, unlike appendicitis. But if you're worried about the disease, that's 30 sleepless nights waiting to hear back if you might have something that's suspicious for cancer in your breast. So we said, what can we do to decrease those number of sleepless nights? And basically what we've said, using technology, using innovation, both technological innovation and workflow innovation, we've created a system so that if a woman gets a mammogram anywhere in our system, whether in our flagship large medical center here in Capitol Hill in DC, or our smaller medical centers in northern Maryland or the middle of Virginia, when that woman gets a screening mammogram, within 30 to 60 minutes, she will get on her phone a notice that says, here's the final results of your mammogram. We've literally taken the mammogram, sent it over the internet, and have our radiologists, our doctors who read the examinations, reading them real time, and then getting the final results out to the patient. And so basically, we're treating breast cancer sort of like appendicitis in the ER. This is an emergent patient cancer for the diagnosis from the patient's point of view. And we're putting things in place that allow her to get those results very quickly. Of course, more often than not, the results are perfectly fine. She has nothing to worry about. But if there is an issue, there's a phone number for her to call. Come back, get a breast ultrasound or more mammograms. And then hopefully that's okay. If there's something there, she'll be seen on video, talking with the radiology doctor, looking at the pictures and saying, to the women, we see something that may require a biopsy. Why don't you come back today or tomorrow? And we have patients who they're feeling fine in the morning, completely asymptomatic, come in, get their screening mammogram, get their recall imaging, get their breast biopsy that day. And by the next day, by 6 p.m., she knows if she has breast cancer or not. So that's taking a journey that would previously have taken many days, if not weeks, to get her diagnosis of breast cancer, now can be done overnight. And so we've really decreased those number of sleepless nights through innovation. And that's something that we're very proud of.
Thank you for that. And Dr. Ashkan Monfared, he's with the George Washington University Hospital. And again, doing amazing work, basically focusing on everything in between the ears. So focusing on hearing implants, as well as on working on tumor removal. And we talked a little bit about some exciting work that you're doing, looking at sickle cell disease and hearing loss, as well as 3D printing models. And so you've got a plethora of innovative work that you're doing right now. Share a little bit about what you're working on with our audience, and also talk about some of the challenges that you might be facing and confronting with this issue, with the work that you're doing as well.
Of course, I'm delighted to be here and on this esteemed panel. So I'll cover the sickle cell projects first. So I'm a director of Otology, Neurotology, meaning that I deal with, as Eric said, anything hearing and ear related, also all the tumors of the skull base, such as acoustic neuromas, meningiomas, and things like that. Being situated in the nation's capital, we are very fortunate to have a very wide spectrum of patients we see. And with that comes, major disparity in terms of availability of healthcare. And on the other hand, for almost 2 decades, I've been doing work internationally at different countries and trying to make the expertise that we have in the United States available to other countries. So that's where these projects originated from. The sickle cell project really started with the story of a young woman who was a nursing student and has severe sickle cell disease, and very quickly lost hearing in both ears due to sickle cell crises. And we made the diagnosis quickly and got her into a cochlear implantation for both ears very quickly. And after I did the cochlear implants for her, she was able to go back to nursing school and continue her journey. From then, I just got interested to learn more about the condition and realizing that there was very little written about sickle cell and hearing. And we reviewed the entire world population hearing data that was available to us and published on what is the rate of sickle cell worldwide. And then we realized it's a very high rate in Washington, D.C. We have a large African-American population in Washington, D.C. About 40% of our nation's capital are African-American with very high rates of sickle cell. So from then, we have started in collaboration with the Children's National Medical Center, a project on hearing screening, early diagnosis, and rehabilitation of patients who have sickle cell disease, particularly when they are afflicted with sickle cell crisis. In terms of the 3D model that you mentioned, I realized when I was doing these medical missions, providing training in art of, for example, middle ear surgery, requires 5 years of training, requires expensive equipment, and then requires temporal bones, cadaveric temporal bones to practice on. So when I was at Stanford this is about 15 years ago, I started this project of creating a replica of the middle ear using 3D printing models. And over the years, it's become so good that we can actually make these, with a resolution of 10 microns, with bones and ligaments and nerves in them, that novice surgeons can actually practice in this model and make it available worldwide. And thankfully, as of now, it is available We are working diligently on making the price cheaper and cheaper. My goal was to make it $1 per cartridge that they can practice and dispose, but the resolution of these 3D printer requires very advanced printing, and we're not there yet, but we're getting close. So.
Thanks so much for that, Dr. Monfared. Now let's go to Dr. Pomper. He's at Johns Hopkins University, and Johns Hopkins is not only doing innovative work in the medical field, but it's also completely revitalizing a community and a city. But let's talk first about the work that you're doing on the medical side in terms of the groundbreaking work, particularly around cancer work that you're doing. In fact, I know someone who's gone through some experimental treatments that you all are doing there. So share a little bit about your work with our audience as well.
Sure. Thanks a lot, Eric. Really extreme pleasure to be here on the panel. So I am actually an imaging scientist, a nuclear medicine physician, radiologist. And what we do here at Johns Hopkins is we try to apply and develop ways of implementing precision health. It's a term that seems to be going around quite a bit lately. But what it means is that we try to look at each patient very independently. We look at their genetics, we look at their environment, we look at their lifestyle, and we try to use that in order to come up with very specific ways of helping manage them across their entire medical journey. And even before that, if we can do a certain amount of prevention, particularly in the community. So in my area, in imaging, it's a little bit different because I think that what precision health, precision medicine does, we look at the genetics, et cetera, but that sort of provides on the ground intelligence about the patients. The imaging sort of enables us to provide guided missiles to treat various diseases like cancer, for example. So now we're developing precision imaging agents and then what are called precision theranostic agents. So my particular area is prostate cancer, which is a big public health problem. 1 in 6 men get it. Around the world, there's about 1.3 million cases annually. So we developed these very specific agents that only hit prostate cancer. We could see lesions that are very tiny. And what's important about that is that we can detect these cancers very early. So the great gift that imaging has to the world, that radiology has, is the ability to detect things early. And in particular with cancer, it's, I've read some articles that say that 2/3 of cancers are bad luck, which means that no matter how much kale you eat, no matter how much time you spend on a elliptical, there's nothing you can do about it. 2/3 are just bad luck. So what can you do? You can either prevent it or you can detect it early. And that's what we're focused on. So we have these imaging agents that use a technique called positron emission tomography. And they're used in conjunction with a therapeutic agent. So we'll detect the cancer when it's very tiny. And then we come in, we change these imaging agents are radioactive. We could change the isotope from something that does imaging to something that does therapy. And then we can follow up with a therapeutic and take out that cancer before it has a chance to get all over the body, metastasize, and do all sorts of other horrible things. So that's what we're focusing on. And there are a couple of these drugs that are literally, there's one about to be FDA approved next week, one of the first ones. These agents have been used worldwide, and they've been used in, they can be used in any country. Thousands of people have already gotten them, but more or less on an experimental basis. But it's a new way to treat cancer, very little side effects. One last quick story was that we had a patient that had a neuroendocrine tumor. This is a very debilitating kind of cancer. There's really no good way to treat it. These radioactive theranostic agents will come in, they'll home in on the tumor, they'll wipe out the tumor. These patients have terrible diarrhea, nausea. They can't really do anything. And we treated a young man, with a couple of cycles of therapy. He was able to, his diarrhea stopped. He could go back to work. He could travel. He could play with his children. And it's really just been a real boon, much less toxic than standard cancer therapy. Happy to discuss it further if you like.
You know, you just made me nervous there. I actually use my elliptical easily 3-4 times a week and eat kale at least twice a week. So you got me wondering whether or not I should stop doing that.
Well, yeah, no, I think you should just keep doing it because it's good for a lot of other reasons. So
okay, great, thanks. And finally, but certainly not least, we do want to hear from Dr. Alejandro Lopez-Magallon. He's with Children's Hospital. And you all are doing some pretty fascinating work along AI in your ICUs. Talk to us about that and what it entails.
So, good morning, and thank you for the opportunity to share this experience. I'm a pediatric cardiologist myself, and I've been working with children and young adults with congenital heart disease. There's two issues, general issues that are steep problems while attending this population. One is the sheer number overall, throughout the world. We have literally millions of young adults and children with congenital heart disease. So the first issue is the access to expert care. Developing the expertise to treat this population is a steep learning curve that requires years of training, and how you share your expertise, that's one. And once you have access to the expertise, then there's a lot of things that can go wrong in a very fragile periods of life for these children and patients. One would be shortly after birth, and other dangerous moments are around some needed or emergent interventions, surgery or interventional catheterization. So a lot of things can go wrong before and during and after these events. We have nowadays a lot of information. There's not a problem of lacking of information many times. Now with the digital technologies that we have and electronic medical records, we have a trove of data that can be overwhelming, and it's for sure overwhelming. How to sear through all this maze of information and get the good stuff to have some decision support is difficult. So that led to my two main interests that are first getting mining data from medical records and imaging studies and so on. So we have been working on developing artificial intelligence models specifically tailored for a very specific population of patients with a funny heart, like a single ventricle heart. Usually the heart has 4 chambers, but many of these patients have just 3 chambers, one pumping chamber, the ventricle. And their physiology is not the same as their oxygenation is not the same. So we had to develop specific AI tools to track the trends from many sources of information, the remote monitoring, the medical record, and labs, and pinpoint us to which patient to take a look at a particular time, to take care virtually of patients when they need it, and review the data and then communicate with the bedside team. So we have been working to develop these hybrid teams. With one is a traditional team, is the bedside team, and another one is the virtual team from a tele-ICU command center. all of them working together to improve quality and safety of care for these patients.
Thanks so much for that, Doctor. We really appreciate that. Now, we've got about 20 minutes left, and always with these events, there's so much to talk about in so very little time. And so what I want to now get into with all of you, because one thing that you all share in common is that you're all in the what we call the DMV region, the DC, Maryland, and Virginia area. And you all are working on fascinating, forward-thinking, innovative technologies. And while this is the nation's capital that undergirds where we are right now, there's still a tremendous growth and inequality and access to a lot of these innovations. So what I'd like for each one of you to do is talk about that and talk about the challenges to ensuring that people not only in these communities have access to the care that you're referencing, but also what are some of the inhibitors or prohibitors that might keep people from around the globe from accessing the technology that you all are focusing on? Dr. Wollman, can we start with you, please?
Sure, thanks. And I think that's a great question. Healthcare equity obviously is a very important aspect to consider, certainly for us in Kaiser Permanente, as well as the country as a whole. I think we're fortunate in that we're fairly unique in that we're actually two organizations. We're the Kaiser side, the health plan side, the insurance side, and the Permanente side, the doctor side. And they're different organizations, but they're joined at the hip. So that allows us to basically do, from the physician side, what we feel is best for the patient and not have to ask the insurance side sort of a mother may I for everything we want to do. So I'm proud to announce that, using the other example for breast cancer, that what we're doing in breast cancer diagnosis is what I call concierge medicine on a patient, on a population basis. So we've actually, there in the United States, there's a discrepancy in breast cancer survival rates between Caucasians and between African Americans. And it's a sad thing, but it happens to be true. Here in the Mid-Atlantic, we've eliminated that discrepancy. Our African American patients, when we're reading mammograms, I have no idea of the ethnicity of the person whose mammogram I'm reading. It's one size fits all. And so we're able to implement the innovations that we're able to make for the entire patient population, regardless of ethnicity or background or any sort of demographic. And so I think it's an advantage of having sort of the care delivery side and the insurance side being integrated together.
And Dr. Monfared, can you speak a little bit about some of the issues that perhaps you may confront, given where you are right here in the nation's capital as well?
So in terms of local issues, George Washington is a non-for-profit institution. So thankfully, we do accept a lot of different insurances and can provide for care from every walk of life. But that is still an issue in terms of access. Sometimes something as simple as having a ride to get to us. So telemedicine has become a wonderful resource for us. Other times is something as simple as having somebody watch the kids so the patient can attend, can come to a doctor's visit. But the disparity, a lot of times goes back to racial background, in terms of education background, level of, education somebody has, and a lot of times just, resources that they have available to. So we do our utmost at GW to be at service by having satellite clinics and telemedicine to everybody and everyone we can. But it is interesting that the nation's capital has such a huge disparity. So it gives, keeps us humble at all times.
Well, I want to push you a little bit because you're doing some amazing work. And you talked about this 3D printing model, for example, and how you've actually reduced the cost to make that more accessible for people that are studying. Mm-hmm. And so I want to hear from you about how the innovative work that you're doing, how accessible will that be eventually? And what are some of the challenges that you perhaps are seeing to be able to get greater access beyond just what you're doing at GW, but talk about the actual innovations in the work itself that you're doing.
Sure. I mean, over the past 20 years, being part of GW and Global ENT Outreach, which is a nonprofit group that we use to travel the world and train folks in ear and hearing care, very quickly discovered that the main obstacle wasn't actually availability of innovation, it wasn't even money or resources. It was actually people's attitude towards healthcare. There really needs to be a major shift in our thinking, as human beings are citizens of a global country. The whole planet is becoming one country, and I hope we have all learned from what happened with the pandemic that really a person can sneeze in China and the rest of the planet would be affected by it. So we have become a family, and I think what will drive the availability of healthcare and improve quality of life worldwide wouldn't be just innovation. It would be a change in people's idea about what healthcare is, which should be an unalienable right of every human being all over the planet. So the reason I started this 3D printed model was that in many countries in the world, for example, temporal bones are not even available, or they're illegal to harvest, to use for training. And we started in countries and started with residency programs and trying to bring innovation to them. And very quickly, people's ego got in the way or political situation got in the way. And it came out to that if people's issues, that human factor is not solved, everything else is going to lag behind dramatically.
I certainly understand that phraseology. I'm from the city of Detroit, and 40, 50 years ago, the saying was, if the big three sneeze, the rest of the world caught a cold. And now, we're looking at a global pandemic where you're right. These issues have tremendous impact because the world has gotten so much smaller. And Dr. Pomper, you're working on an issue that still continues to both vex and push the global community. And we're talking about the issue of cancer and the treatments and the innovations that you're working on. You talked about the young man who had the issue and how you all were able to address that. But talk about how accessible this is, not just in the community where you are, the city of Baltimore, but also what does this mean for a global audience to be able to have access to these types of new innovations?
Yeah, huge issue, obviously. And just to echo what Dr. Monfared had just said, I think that we're not technologically limited. The sort of stuff that we do is so incredibly complicated. I mean, with PET scanning, we need chemists, physicists, etc. But this is not what our limitations. It doesn't arise from that. It arises, frankly, from as mentioned, political issues or issues of what the patient's attitudes are. So at Johns Hopkins in Baltimore City, I mean, we've been here for about 130 years, but I have to say that, and I've personally been here for about 30 years. I was a medical intern here. And probably the most important thing that we could do to get things like this high tech out to the community is, number one, gain the trust of the community. The hospital here has a long history of doing medical research, clinical research, one of the first research, in fact, the first research university in the country. And yet I think that patients are still wary and hesitant. So number one is that. And then number two are the social determinants of health. Those are vastly more important than a lot of the innovations that we're talking about today, the specific innovation. But these specific innovations have to happen like this. They have to be very focused. And then hopefully they could eventually be generalized. So, for example, in our area, with these imaging agents I was talking about, we could detect 2 millimeter lesions from prostate cancer. I mean, can you do that in sub-Saharan Africa? Can you do it, in North India. One is going to have trouble doing that unless they have access to certain equipment, certain personnel. We have had heads of state that, right outside my window, there's an old entrance to the hospital, and we never use that entrance unless a president from some country, drives up there to get their treatment. We've had heads of state come here just for this imaging agent, and then I look and I see 600 yards away, across Orleans Street, there are some of the most, I should say, difficult communities in the country. So what we can do, what I've tried to do, and there are obstacles here, is try to get this high tech right out to the community where we'll make it free of charge. We can advertise, and in fact, we'll even pay for it to get men with prostate cancer that have no insurance, no access. There is a program at Johns Hopkins called the Access Program that will go into the community and try to engage people with the health system. And, I've tried to do that with some of this high tech, and it's a challenge, and it's about the patient's attitudes. But these technologies, where there's a will, there are trials being run with some of these in many in Puerto Rico, in Oceania, in New Zealand. It's just a matter of recognizing a problem. But the beauty of the early detection is that it inherently decreases disparity. If everybody had access to early detection, like a mammogram, for example, then the care that people get comes together. The woman who goes every year to get her mammogram and detects a little tiny lesion is going to have a lot different care than a woman with no insurance that doesn't get detected until she has a golf ball sized lesion. They have totally different care, but their care will all come together if we can catch it early. So it's a political will. We could talk about the healthcare system being unsustainable in terms of its costs in the United States. A lot of big issues, but I don't know if we'll solve them in the next 10 minutes. But these I think about every day when we try to do this high tech stuff.
This is very fascinating because what we are seeing and what we're talking about is, how do we deliver this innovation across community, across these inequities, but also across borders as well. And we do know, as you just mentioned, a number of people come to the United States for care because the United States is seen as a leader in healthcare and innovation. And right here in the United States right now, there's so much discussion around children and vaccines, given that we're still addressing and dealing with a deadly pandemic. And Dr. Magallon, you work specifically in pediatric care, and with the work that you're doing on AI, we've already talked about one of the tremendous barriers that oftentimes, doesn't get the attention that it should, and that is our own hesitancy with a willingness to actually take advantage of a lot of this innovation. And so is that an issue for you when you're talking about this type of innovation, this type of forward-leaning technology, and what it means for children, because you use this primarily in the ICU where it's an emergency situation right now. But what are some of the barriers that perhaps you see or that you all are grappling with to try to make this accessible not only to people in the DC, Maryland, Virginia area, but also people who may want to come to the United States for access to this care?
Okay, yes, I see many of the same issues as Drs. Wollman and Monfared and Pomper, but also particular ones related to what I do. As you mentioned, these are patients I treat usually in a cardiac intensive care unit. So I don't see an issue with the patients and families. Some of the issues are regulatory and financial, and not technological anymore. We can deliver this model of care and share expertise using AI models and assisted with virtual technologies. And the patient can be in our own hospital and can be in some other hospital within the US or abroad. It doesn't matter. There's the same model of care. The issue, paradoxically, is on the health community side. I think we have a paradigm in health community that we have is health facility-centric model mindset. And we don't consider as much as we want to, there is realities that institutions don't consider as much the input from families, the perspective of patients and families as we should. And that was the pre-pandemic situation. After the COVID pandemic, I think the collective mindset is maybe ripe for some pushing for some fundamental changes and pushing forward some agenda that is already ongoing. What I mean is that we are, as a society, migrating from the perspective of healthcare and technology-wise overall is from institutions to closer to patients' homes and even to each patient and family. So things are moving from hospitals to the mobile phone, and it's going to be the same. This is going to be an accelerated process. And I do see the silver lining I saw is that we were able to really start and deliver, just to give you an example, we at Children's National Hospital, we had a pre-pandemic average of telemedicine consultations of around 80 to 100 per month. That really increased manifold to an average of 8,000 to 10,000 teleconsultations per month in just a few weeks. So, and we're still keeping, more than 8,000 teleconsultations per month, even, last month. So that is an example of how you can, it's really sometimes a mind and regulatory, obstacles to this to come to fruition. I hope we can learn this from this experience and use what we learned to get expert care closer to patients' homes.
Thanks so much. And I want to thank all of our panelists for being with us today. Thank you all so much for taking time out of your very busy schedules to share with our audience just all of the exciting and innovative work that you all are doing. We do know that there is a global audience that looks to the United States for this type of forward-thinking work that you all are doing on a range of different issues. But also, too, we do know that the care that you all provide is not only a bridge to the rest of the world, it's also a bridge to those communities right here that you all serve on a daily basis that so desperately need the work. And we certainly thank all of you for that. Also, I want to thank our sponsors, Cigna, Kaiser, Permanente, Children's Hospital, George Washington University, for all of your effort in this conference as well. And for those of you that are watching, be sure to take part in our expos as well as our networking sessions as well. Thank you all, and be sure to stick around for our next session where we are going to be discussing the issue and the impact of mental health, particularly over this last year. Thank you so much.
Great. Thanks
so much.
Thank you.